Welcome to Six Patterns video series on YouTube. My name is Max.
I'm Kevin.
And we are coming to you a little bit differently than we have in the past. We just finished our Top 25 Pearls video series that we had a lot of fun making, and it seems like the viewers had a lot of fun reviewing those videos. And we had a lot of fun interacting with the comments and whatnot. But that video series has completed, and it finished right in the middle of the COVID pandemic, which has led us to investigate other avenues to be able to produce more videos. So here we are coming to you through a virtual Zoom meeting recording. So we hope that this format works for you, and we also hope that you're doing okay out there, and that this pandemic will be behind us in the near future, and we can get back together to doing side-by-side videos, because it's more fun to do it next door to you, Kevin.
And the chemistry. I mean, face-to-face, in person, you can't escape it, It goes all the way back to the cave days.
That's right. People tend to enjoy people. It's very true.
Yeah.
So as the Top 25 video series was ending, we were thinking, what type of series? I mean, we could do individual cases here and there, but we thought that the series idea really was had a nice thematic ring to it, and it allowed us to put together a series of videos together. And so we were thinking, what should we do for the next video series? And Kevin, let them know what we came up with.
Well, we thought exploring things that aren't generally grouped together because we don't think of them by their pathophysiology. We thought that would be a great way to approach some cases, to group them based on something about their pathologic anatomy. And we came up with this idea of the vasculature of the lung. It's kind of, it's so obvious that it's so important to lung function, and it's so obvious that it's affected in so many diseases. We thought it would be good to dive into these and really talk about some of the things that people don't talk very often about, like how do you evaluate a biopsy for pulmonary hypertension?
Right.
Veno-occlusive disease, capillary hemangiomatosis, pneumoconiosis, all the things that kind of slide by because they're not tumors and they're not as presumably exciting as tumors. Max and I find the tumors to be exciting in their own way.
Exciting in a boring way.
The medical diseases are complex and like playing three-dimensional chess, because you have to take into account so many different factors. But in doing it, in exploring these cases with us, you'll find, I think, that your comfort with, and not being afraid of these compartments, of really being the master of this domain, I think is going to be exciting for you. And we hope you guys will give us feedback and other ideas moving forward where we could do deep dives.
Absolutely. So the series, we're calling it Deep Dives in Pulmonary Pathology. And the first sort of segment that we're going to bite off and chew on for a little bit over the next series of cases is going to be the pulmonary vasculature and lesions that affect the pulmonary vasculature. It's often overlooked in the setting of interstitial lung disease and biopsies for interstitial lung disease. And so obviously the vasculature is not the interstitium, and so that's why maybe it's perhaps overlooked. But we're going to talk about a whole bunch of lesions that impact the pulmonary vasculature and thus end up on your surgical pathology desk, and you're like, I don't know what to do with. So hopefully by the end of this series, we'll give you a nice approach to how to assess the vasculature within the lung.
Nice.
All right. So with that introduction, we'll get started with our first case. This case comes from a young woman, 20-some-odd-year-old patient, and she presents with shortness of breath and cough, and she gets high-resolution CT scan done, and high-resolution CT shows innumerable fine nodularity throughout the biopsy, upper and lower lobes, but maybe slightly more prominent in the lower lobes. And the nodules are read by the radiologist as having a centrilobular distribution.
Interesting. Wow, when somebody says centrilobular distribution on CT to me, first thing I always think about is inhalational disease.
Absolutely. hypersensitivity pneumonitis. In fact, I think our pearl on hypersensitivity pneumonitis, we went over that, central lobular nodules.
Yeah. But what's interesting is another kind of generalization is that things that make central lobular nodules in the upper lung zones are inhalational, but things that make central lobular nodules throughout the lungs, maybe with a predominance towards the bases, might be vascular. Now, how could vascular be central lobular, Max?
Well, you go back to your bronchovascular bundle, right? And in that bronchovascular bundle, you've got your airway. That's why we think about central lobular lesions as being inhalational. But you've also got your pulmonary artery. And so vascular lesions and the blood flow through the lung is more prominent in the lower lobes than it is in the upper lobes, and more prominent in the dependent portions. And so bronchovascular distribution or airway-centered or central lobular distribution can include vascular abnormalities. And then there's one other thing that runs through that bronchovascular bundle.
Lymphatic.
The lymphatics. So a diffuse pulmonary carcinomatosis, a lymphangitic carcinomatosis, can often present central lobular nodules as well.
Usually, but you'll also find pleural-based nodules, and you'll see beads on a string like sarcoid, because sarcoid is a lymphatic distribution, or what radiologists call perilymphatic. But that lymphatic distribution includes the airways and the bronchovascular bundles, but then it also wanders to a place where the bronchovascular distribution does not go, which is the pleura and the interlobular septa. So those are like key concepts. And once you know that, it's like lightning flying from your fingertips. You're going to start saying, well, I need the CT report to tell me more. Where are the nodules?
The CT scan, we've said it before, say it again. The CT scan is your gross inspection of the lung. You're not going to see much when you look at this wedge biopsy grossly at the gross bench, but the CT scan gives you the entire gross picture of the lung and the distribution of disease. So it's like a get out of jail free card. It's a free pass. It is, if you have access to a CT scan and you're not reading it, or you just don't need to read it. And I mean, actually look at it. Look at those images. It can be very, very helpful with distribution of disease. So Kevin brought up the key component of distinguishing a lymphangitic process versus a true bronchovascular process. And he said the lymphatics run through the interlobular septate and the pleura and the bronchovascular bundle. A lesion that's just affecting the bronchovascular bundle will not be present in the pleura in the lymphangitic space. So we have...
the radiology, by the way, when they talk about a central lobular nodularity, they say that the nodules get close to the pleura but never touch.
Yeah, they call that
because airways
sparing.
It's kind of a subpleural sparing thing. But so the nodules get close and they'll point out that, see, it doesn't go all the way to the pleura ever. That's a central lobular criterion.
Right. So we have this biopsy from this patient. We had the CT scan, multiple nodules, bilateral, slightly lower lobe predominant. And we, I think, are seeing from this very low power, multiple pulmonary nodules. So already I'm feeling pretty good that we have a biopsy that's representing the abnormality on the CT scan, which is probably why the patient is presenting. So I'm feeling like we are on the right track, like we haven't missed something here in the clinical history. And even from this power, Kevin, even from this power, what is your assessment of the distribution of disease?
So the branching emphasizes the bronchovascular distribution, even if it's not just artery. The airways will also have this branching appearance when there's pathology.
And what about the pleura here?
So take it, Max.
So what about the pleura here, Kevin? The pleura here is completely uninvolved, right? We have no involvement of the pleura. So going back to our radiology, we have central lobular nodules. Normally we think about inhalational diseases, but we have to worry about lymphangitic diseases. And we can say fairly confidently that there is zero pleural involvement and zero involvement of the interlobular septae. So we can exclude the possibility of a lymphangitic process here. So lymphangitic carcinomatosis, sarcoid, we can disregard some of those things. So now when we come here and we start looking at some of these pulmonary nodules, I think we can start to get a sense for what's going on here in this pulmonary nodule.
Isn't it interesting, Max, that it's taken this long in the video for you to actually talk about what has been the elephant on the fence, right? Which is, what the heck are these nodules? Because context is everything, folks.
That's right. 10 minutes into this this video, and now we're finally talking about what we're actually seeing in the nodule, right?
And now it becomes easy.
Oh, with this lead up, it's super easy, right? This is a multinucleated giant cell. It's surrounding something foreign. If we had a polarizer on our microscope, we could polarize it, and it would be widely, highly polarizable. This is foreign material. But that begs the question, Kevin, where is this foreign material? We already talked about that it's in a bronchovascular distribution, but is it in the airway? Is this inhaled material, or is this vascular material?
Yeah, so these are great questions, and there's a little bit of peculiar science associated with particle size in the lung. You know, what's interesting is that big chunky things, like over 50 microns particles, tend to be inhaled particles. You know, and it's interesting that some of these pieces are pretty big, but some of them are very small. So if you did a EVG stain, elastic tissue stain, you'd be able to track the arteries, the pulmonary arteries through here. And what I think you'll find, and I'm sure it was in this case, is that these are in the vascular sheath. These are the pulmonary artery sheath. There's an artery coming into this, and this material has migrated out of the artery, in many cases, into that space to make the nodule where the giant cells are accumulating.
And I think it's a pretty consistent finding, right? You'll see that everywhere that we have this collection of multinucleated giant cells, there are small terminal pulmonary arteries that are associated with, small to maybe even larger, terminal pulmonary arteries that are associated with this multinucleated giant cell reaction.
Yeah, it's very cool. So you remember, the giant cell reaction is probably local. You know, we tend to think, we see stuff and we go, oh, look, that came from somewhere else, so the whole thing came. I don't think so. I think that material came in the artery, and I think it migrated out of the artery, and I think the lung has done these nodules with giant cells.
Exactly. And if it was inhaled, you might expect most of it to be in the airways that we're seeing here. And we're not seeing anything in the airways. All of what we're seeing is adjacent to these larger arteries. Okay, so the million-dollar question, Kevin, so an EVG might help you identify the vasculature, and I think anytime you are thinking about the possibility of a vascular lesion, right, this is one of the things about an approach to vascular lesions, it can be very helpful to get an elastic tissue stain in order to help identify exactly where those pulmonary arteries are. I like an elastic trichrome stain because I think it adds a little bit more than an EVG, but whatever you have to evaluate for pulmonary arteries and elastic stain can be quite useful in the workup of pulmonary lesions in the lung.
I don't think we used a movat stain very much in the practice, but the movat's a kind of a nice stain too.
Yeah, some people love the movat. Some people won't sign out a lung specimen without a movat stain, but it can be nice. I think it's rare that you actually need it, but it can be quite nice. Here again is another example of that vessel where we have this robust foreign body giant cell reaction adjacent to the vessel.
Cool. So tell us the story on this then.
So the material polarizes, Kevin, but what is the next step we can do to help identify what this material might be?
Well, I don't want to go to X-ray diffraction. Yeah, that's like $750. And it might be useful for a forensic exploration, and there may be reasons for that medical legally. But key thing here is, if I see this material and it rotates plain polarized light, meaning it polarizes, I get a GMS stain. Because if this is what I think it is, I think that's microcrystalline cellulose. It could be talc, but it's not as platey looking. The crystals aren't as platey as talc. They're more fascicular, like made up of tinier shards.
Yeah.
And I think that's going to be
a little bit more wavy than what you see in talc.
Yeah. I
so
think
exactly,
this can
on GMS, the microcrystalline cellulose will be positive, right?
Right.
And talc will be negative by GMS. And so what's the point? We're talking about microcrystalline cellulose, we're talking about talc. And the point is that this material is here in the lung in a pulmonary artery vascular distribution, because this patient is taking pills, it's usually opioid derivative pills, and crushing analgesic, crushing them up, dissolving them into solution, and then injecting them
into the veins.
Because you can take it orally, you can snort it, but the quickest high is with this.
Not from personal experience, of course, but from what we hear, the quickest high is injecting. Don't do it.
Don't do it. Don't even consider it.
When you solubilize that pill and you think you've got a bubbly, crystalline, beautiful, clear thing, it's actually filled with this material, because that microcrystalline cellulose is the binding agent for the medication. It's what makes the pill into a solid, moldable form. And all that stuff gets into your vein, and it goes into the most perfect filter in the world, the lung.
And the downside, of course, is that there's no removing this stuff. There is no way to dissolve this. Once this is deposited, this is going to be there forever. And you can imagine these patients are going to have significant compromise of their pulmonary vasculature, probably developing pulmonary hypertension.
Correct.
And in fact, there's an artery in here that is a little bit dilated, actually quite a bit dilated compared to the adjacent airway, right? This pulmonary artery is a lot bigger than this adjacent airway, suggesting that maybe there's already been some pulmonary hypertension that's developing as there's more pressure here.
Good point.
What should we call this lesion? What should we call this lesion, Kevin?
Well, let's call it pulmonary.
I think the word pulmonary is in there.
Let's got about pulmonary. Let's call it something to do with pill and crushing. How about pill crusher?
Pill crusher.
Okay. How about pill crushers, meaning it belongs to the pill crusher?
Right.
Pill crushers, pulmonary.
Some people have called it pulmonary. Some people have called it pulmonary talcosis in the past.
Yeah, it's hard if it's not talc.
But it's not really talc anymore. Talc is rarely used now as a filler within medications. It's this microcrystalline cellulose. So it doesn't make sense to call it pulmonary talcosis anymore. It's really a lesion of the vasculature.
Right. And a lot of talcosis is inhaled talcosis.
True.
So not even vascular oriented. So how about if we call this it's a microangiopathy. So say the whole thing, Max. Just
do it.
I dare you.
Pulmonary microangiopathy.
Wow. You heard it here first, guys. Made up on screen.
I think that sounds pretty good.
Maybe. Or we could have heard somewhere else.
Prognosis for this patient is not good. Obviously, you need to stop adding more material to your vasculature. But again, like we said, this is not going to be going away anytime soon.
It has huge implications. I've seen it in the setting of lung transplantation, where the lung becomes destroyed by this, and the patient is doing this, and of course, nobody knows secret activity. So remember, when you see this, I want you to stop and think about the implications. If this is, for example, is a police officer's lung biopsy, I want you to stop and think carefully about making sure that you have colleagues on board with that you're correct in your diagnosis, that you don't throw it out willy-nilly, because it does have rather dire consequences by implication.
Absolutely. So make sure you're sure of it. Get that GMS stain, get the elastic tissue stain, show it to your colleagues if they've never seen it before, maybe send it out to somebody who has.
Yeah.
All right. So hopefully you guys enjoyed this video. Hopefully you learned something. I think this pretty much wraps it up. So don't forget to like and comment below. Let us know how you like the new format. I think Kevin is now on Twitter too. So maybe I'll try to add a Twitter handle here to the end of this video.
Yeah,
ours is at 6patterns, but I think Kevin's got one too.
at lung path guys, one word.
At Lung Path Guys. So I'll try to add a link here to the end of this video. So thank you very much.